Hello, I'm Chris Salisbury, and today I'm talking to Martin Marshall. Martin's chair of the Nuffield Trust, which is a leading health think tank in the UK, and he's also Emeritus Professor of Healthcare Improvement at UCL. But he's had lots of other roles, as we'll soon discover. So, Martin, thanks very much for joining us. I think I first met you when you were a senior lecturer in general practice in Exeter in about 1998. So just give us a quick recap of how you got to that point. Had you always wanted to be a GP? Had you always wanted to be an academic? Tell us your story.
Yeah, so I was the first member of my family to go into medicine, so I didn't have a clear perception of what the opportunities were available to me. But as I worked through medical school, certainly by the end of medical school, I knew I wanted to be a GP, partly because I enjoyed every specialty and I couldn't imagine giving up psychiatry or pediatrics or whatever along the way. Partly because for a rather negative reason that I don't like hierarchies. I'm a free spirit, and that kind of suits being a GP rather than working in a big structured hospital, if you like. But I think mostly because I in that typical GP way, I quickly realised that the thing that gave me a real buzz was people rather than diseases. And understanding the human condition, understanding how people respond to health and well-being and ill health is what really fascinates me and gives me a buzz. So yeah, I knew I wanted to be a GP, and I went straight into my GP training from my house jobs. I didn't know that I wanted to become an academic. When I was at medical school, I did a BSc in biochemistry. I did some lab-based research, and I still remember what it was, the elastase-induced emphysema in the rat lung. So I spent time playing with test tubes, and I thought, if this is what research is about, it's really very boring. So I didn't really have any other inclinations towards an academic life until I finished my GP training. I was offered a partnership in the practice that I trained in. It was a part-time partnership for 2 or 3 years until the senior partner retired. So I was looking for other things to do with the rest of my time, having started as a partner. And I almost by accident fell into becoming a research assistant in a health service research project, and really enjoyed it. And with the help of a couple of very good mentors at the time, I decided then to do a master's, and I got onto the slippery slope of academia, and found I really enjoyed social sciences. That's what really gave me a buzz. So I guess my academic career was not planned, not thought through, but something that I've enjoyed enormously.
So you did around that time, or soon after that, you did a Harkness Fellowship, didn't you? Is that right? Do you want to just tell people what Harkness Fellowship is for those who don't know and what it meant to you?
Yeah, the Harkness Fellowship is a travelling fellowship to the United States, available at the time that I did it to English-speaking countries, so UK, Canada, New Zealand, Australia. Now it's more broadly available. It's a kind of early mid-career type fellowship funded by a foundation, an American foundation called the Commonwealth Fund of New York, and it gives you an opportunity to spend a year in the United States, learning with the leading kind of health service research thinkers, and it was a fantastic experience, a particularly good one for me really, because I'd been in my practice, building my research career. I'd got a doctorate. I was a senior lecturer in Exeter. They were very interested in my background as a GP, something that they weren't familiar with in the United States particularly. So I managed to get appointed, went out there with my wife for a year. We had a wonderful time, just exposed to the best thinkers in the field, particularly in the quality of care field for me. I was based at Rand in California, in Santa Monica. And that completely changed my horizons really, from being someone who was committed to being a GP all their career, doing a bit of research on the side, to somebody who had a different set of ambitions. So as soon as I came back, I handed in my notice to my colleagues in the partnership and moved up to Manchester, where I developed a kind of serious, nearly full-time academic career alongside my clinical practice.
Mm-hmm. Yes. So you moved up to Manchester, and then you weren't there that long before you were on the move again and became Deputy Chief Medical Officer for England and Director General for the Department of Health. So those are really, really big roles. And it must have taken a lot of kind of confidence and gumption to think that you, relatively young professor GP, could do that and could go for that, and you did it.
Is
Tell us
it
about that.
confidence or naivety on my part? I'm not. I'm not sure. Yeah, I was in Manchester for about 7 years and working in the National Primary Care Research and Development Centre. So was increasingly exposed to some of the kind of policy leaders and civil servants, politicians through the research that I was doing in Manchester, and I became more and more interested in policy and was doing mostly policy related rather than clinical research at the time. And I built a relationship with the then CMO Liam Donaldson, who when one of his deputy roles came up, asked me to apply. I think he liked the work I was doing, and I got on very well with him.
Mm.
So I did apply and I got it, but it wasn't. Yeah, you're right. It was a massive move, and I was pretty unprepared for it in many ways. So shifting from being a clinician running a practice to being an academic working in a university with fairly clear boundaries around you, to then working as a senior civil servant and national professional leader it was a risk. It was one that I learned a lot from. We managed to deliver what we had to deliver, but I found that I wasn't enjoying the role that much, and I found the nature of working in a political environment certainly exciting, but also very frustrating.
Mm.
So the things that you knew needed to be done and weren't done, or bits of work that you might develop to the point of where they might be implemented, and then a minister would suddenly change their mind. So I think some people are cut out to operate in that kind of very political and party political environment. It wasn't an area where I felt I had a lot to contribute, and as I say, I found it frustrating. So I left that role, after about 2.5 years.
Mm. In preparing for this, I reread your James MacKenzie lecture from 2009, which I get the feeling between the lines is influenced quite a lot by your engagement with politicians and policymakers at that time. And you don't kind of pull any punches about how we as a profession need to take responsibility for ensuring quality of care, and how we need to engage with politics and improve how we communicate our purpose. Is that how you still see things 15 years on?
Yeah, very much so. More so, if anything. So I think my two experiences that influenced that lecture, which was James MacKenzie lecture, were with partly my experience of government and recognizing how to get the best out of your relationship with our political masters and senior leaders. But it was also partly a recognition of where my strength was as an academic, which was in asking the questions that are relevant to the service, particularly to patients receiving the service, and then implementing the results, but not the bit in the middle, the bit that most academics love. So I never regard myself as a talented methodologist. My interest was the beginning and the end of the research process, and I was very aware, working in government as well as my experience of working in the service, that a lot of research just gets lost in its own vortex, doesn't have very much influence on practice, and that's a consequence partly of the nature of researchers, who perhaps historically were less interested in implementation, but also on the nature of the clinical community, that they weren't sufficiently interested in pragmatic research and making use of evidence-based findings. So that's where that lecture came from, and I guess I was very aware of how much better general practice could be if it was guided by the kind of practical, pragmatic evidence that myself and many of my colleagues were developing.
It felt to me like you were not only showing a bit of kind of frustration with government and politics, but also in a way with the profession itself. Having been on the other side of the fence, you were saying, if you want to get things better, you've got to take responsibility for making them better and not just make excuses. It was almost a kind of theme that felt to me. Is that fair?
Yeah, it is fair. It is fair, and I think Julian Tudor Hart, that great South Wales GP, once described doctors and particularly GPs as politically naive, and I
Mm.
think I think that's right. I think there is a doctors are driven by a sense of passion and a sense of service, but also I think an inappropriate lack of respect for those who run the system, whether they be politicians or civil servants. A belief that they just don't get it. And working with these people, recognizing first of all how intelligent they were and how often how passionate and committed they were, but also how bound they were by the environment that they're working in, and that's the constraint that we see as clinicians. It made me want to, I guess, push GPs a bit into a space where they understood where politicians are coming from, understood how to influence them, and B, were willing to make the effort to do so. And I guess that's one of the reasons why I shifted from a clinical career to an academic career to a policy career, and then into leading the college, because that's what gave me the ability to exercise that influence.
Well, I'll come to the college in a bit, but a big theme of your work, your academic work, is about measuring and rewarding quality and promoting quality in clinical care and healthcare. And you've talked about the risk of focusing too much on a specific biomedical agenda and then losing sight of things that are harder to measure but important, like patient-centered care, relationships, comprehensive care. And I'd argue that's exactly, in fact, what happened with the quality and outcomes framework, and also more recently with digital consultations, that we're kind of losing all those things with a focus on the individual transaction and the individual biomedical problem. So how do we square that circle? We need to measure things to ensure quality, but the most important things are hard to measure. So it's easier to measure the medical things.
And you've been a great advocate throughout your career of the kind of the broader range of things that we, particularly as GPs, but as medics and as clinicians more generally, bring. I think what's the foundation of good general practice? It certainly is the ability to form relationships with people and to be able to communicate effectively and understand what motivates them. But too often we didn't talk about the fundamental clinical skills that are also necessary to be a good GP. So I understood why the quality and outcomes framework and the incentivization of specific clinical processes came in, because there's no doubt at all that we weren't doing the basics that well. We weren't measuring things that effectively. We weren't committed to improvement. And we weren't working as effectively as we could have done as a multidisciplinary team. And all of those things were transformed by QoF when QoF was introduced. So all of a sudden we started collecting data, we started using data. We focused on clinical processes, which it was an experiment in the beginning, and there were some silly indicators in there initially, but gradually over the years it got better and better. So I don't completely damn QoF, but the prediction that you and I and others made that it would change our focus from what is really important to patients, which is that personal relationship, that deep understanding of their needs, to something which was a much more technocratic function. That happened, and so we had to draw back. We had to consider other ways of rewarding the things that really matter to patients. And I think we've got there. When QoF was first introduced, it represented about 20 or 25% of a practice's income, and now it represents about 7% of a practice's income. So there has been a shift away from rewarding the things which in essence are easy to do, you just need to be systematic about them, to supposedly at least creating space to do the interpersonal care more effectively. Now, have we seized that effectively? I'm not sure we have. I think there's a degree to which GPs have become socialized into doing the technocratic stuff well, and certainly the combination of that kind of cultural background with the environment that we find ourselves in now, which is a highly pressured, overworked environment, in which the easiest thing to do is to close down a consultation rather than open up a consultation, has meant that general practice is not in a good place at the moment, and that's a source of enormous regret to me and to you and to many others, I think.
And you talked about how quality improvement needs to align initiatives with professional values, and how initiatives fail if they don't. And I kind of feel that's a lesson we need to keep on reminding ourselves of, because I think some of GP's frustration these days is because they're being asked to do things that aren't the kind of doctor that they thought they were going to be.
Yeah.
Is that the, how can we recover aligning quality initiatives with professional values?
Yeah. In some ways, I'm less concerned about what we're being asked to do than I am about what we have the capacity to
Mm.
do.
Hmm.
We still have a high level of autonomy. And if we want to operate in a practice which does the basics really well, and you've got a really good systematic approach towards providing care, and then you focus on the other things that are important, whether it be interpersonal care, whether it be whole person care, uh, um, shared decision making, whether it be public health, all the other things that matter. Actually, we have the potential to be able to do those things and to be professionals, to be autonomous and to drive them because they're important.
Mm.
The problem right now is that people simply don't have they might have the capability, they might have the training, they don't have the capacity. And that's the issue that's so hard for
Mm.
people in clinical practice now. It's not an accident that people like you and me, people of our age group, have largely given up clinical practice because we couldn't practice like we wanted to. Um, uh, and I think it's the sheer pressure of the work which is driving clinicians away from being the good GPs that we were trained to be, and the deep frustration that you can't put your training into practice.
Mm. Okay. So then the next big stage, it seems to me, in your career was in 2019, you became chair of the Royal College of GPs. Why did you want to do that? And did you have a particular kind of purpose, agenda in mind, of things that were priorities for you in doing that? And what were the sort of joys and challenges of doing that?
A lot of questions there.
Yeah.
I've always been involved in the college. One of my mentors as a young GP, as a GP trainee, was Dennis Pereira Gray, one of the great leaders of the college. And I've always regarded the college as making a really important contribution to my professional practice. Um, so I was very glad when I was elected. Because I'd had a long time to think about it, I had a very clear idea of what I wanted to achieve as chair, the kind of direction that I wanted to take our members in, and that was partly about rethinking and re-emphasising the importance of relationship-based care. And it was partly about going back to our roots and recognising the importance of population health and the role that general practice can play in population health or public health roles, or whatever you want to call it. So I had two areas that I really wanted to work on and push. I came into office in November 2019, and by January 2020, the pandemic had struck. So, in some ways, everything was turned upside down. So I guess I was chair at a difficult time, partly, or a challenging time, partly because of the pandemic and partly because of the enormous pressures that general practice were just starting to surface at the time that I became chair. So I had two major crises to handle as chair, and that was challenging. It was fun, but it was really challenging as well.
But important, because that was probably the most rapid period of change in general practice in my lifetime. In a very short space of time, we had to completely reorganize everything, and the
Yeah.
chair's the responsible organization for the profession. So, really important time to
It
be.
was, and for that reason, very exciting. It's
Mm.
remarkable,
Mm.
particularly during that period, probably the first year of the pandemic,
Mm.
when the brakes were taken off everything.
Mm.
Essentially, um, there's no limit to the resources that we would make available to you if you do the right thing.
Mm.
So it was really exciting.
Mm.
And as you say, general practice really did transform itself,
Mm.
particularly in terms of
Mm.
non-face-to-face consulting, remote
Mm.
consulting,
Mm.
but also in terms of our contribution to the vaccination
Mm.
program,
Absolutely.
and generally reforming the way that we work. So it was an exciting time, but yeah, it was a tough time
Mm.
too.
Sure. So You've worked across a whole lot of sectors, clinical, academic, professional, political. How does it feel to try and span all those different arenas? What have you learned?
Well, very privileged actually, because I think it's going to become increasingly common for the next generation of doctors to have career portfolios like I've done. It's already very common in the United States, but it wasn't that common in the UK when I started it. And the opportunity to always have a kind of common goal, which is improving patient care, specifically through the promotion of primary care and general practice, but to do that from a range of different lenses, as a clinician, as a academic, as a policymaker, and as a professional leader. So so I've really enjoyed each role in isolation, but most importantly, I really enjoyed working at the interface between those roles and trying to make sense of how we work together across sectors in order to make a difference. And as I say, it was very privileged. And I guess in some ways I'm still continuing that, as in my non-exec roles. I've got a kind of another career now, if you like, since giving up clinical practice and giving up my academic practice and stepping down from the college as a board member, which allows you to definitely use your experience and your wisdom in a more strategic way. So yeah, it's I think I've been very fortunate in my career, and I'm very grateful for the opportunities I've had.
And just tell us briefly about the Nuffield Trust. What does the Nuffield Trust do for people who don't know it, and what are your kind of key priorities there?
Yeah, so the Nuffield Trust is a think tank. It's a policy influencing organisation. It's a charity set up by Lord Nuffield in 1940. There's three health and care think tanks in the UK. The Nuffield is the smallest, but we punch well above our weight. The others are the King's Fund and the Health Foundation. So our role is to influence policy. We do that partly always on the basis of evidence. So we create evidence and we work with others to create evidence in the health service research sphere, so about the organisation and delivery of services. We present that evidence to policymakers and to NHS health system and care system leaders, and to clinical bodies as well. And we critique policy. So when policy ideas come out, our job is constructively and apolitically to critique policy on the basis of the evidence and experience that we have, and to try to improve policy as a consequence.
And summarising all the academic work and making it practically useful to people, the key messages for people. Exactly. But then recently you become chair of the National Centre for Creative Health, which I don't know anything about. So what's that? And tell us about
that. That was a really interesting opportunity that came my way. So as a GP, I've always been interested in having a broad range of interventions that we use, and we've already talked about the biomedical interventions that we use effectively. But I like others, I know the evidence that probably somewhere between 70 and 80% of our health is determined by social factors, not by factors that are within the remit of the NHS. And therefore social interventions make sense, which is why I've always been a strong advocate of social prescribing, even though it's been quite difficult to implement in the NHS. And the National Centre for Creative Health is one element of that social prescribing basket, if you like. And specifically, it's about creative activities. So that's it's the performing arts, it's the visual arts, but it's also any activity that stimulates your imagination. So it might be gardening, it might be cooking, it might be reading a good book or watching a good film, anything that stimulates the imagination. And the evidence is very clear that if our imagination is stimulated, you feel better about yourself. And as a consequence, our health and well-being improves.
So you had a really busy career. If you met your, 22-year-old self, recently graduated, or however old you were when you graduated, what advice would you give your younger self about your career?
Lots of advice, I'm quite sure. Number one, I think our basis, our credibility as senior professionals is based on being a good experienced clinician. So get a really good clinical basis under your belt. The wisdom that comes along with being a full-time or near full-time clinician earlier on in your career, I think is really important. So be a good clinician, number one. Add strings to your bows and don't constrain yourself. Take risks. I think I've described to you some elements of my career which I think have been, they've all been enjoyable. Some have been more successful than others. But each of them have added to what I've then been able to bring, later in my career to the field that I'm in. So I think add strings to your bows and take risks and enjoy what you're doing.
You've certainly done that. I can't think of anybody who has packed as many different roles into their careers as you have done. And I could talk to you about this for ages, but we need to stop. So thank you so much. It's a really great privilege to hear about all the things you've learned from all these different roles and to chat to you. Thank you so much.
It's a real pleasure. Thank you, Chris.
Thank you.